Okay, thanks, Kathy. So good evening, everybody. I'm Beth Rosemurgy. I am the co-chair for the Education Commission for the MAFP and currently the vice president as well. So glad to have you all here. We're excited to have Dr. Jennifer Scheer here with us to teach us about reflecting patient disease burden using the HCC risk adjustment model. So tonight's presentation is delivered live and the presenters are available for questions following their talks. You can feel free to drop questions into the chat window as they come up during the presentation. We'll monitor the questions and moderate them at the end. You can also speak up and ask questions directly to the presenter at the end of the presentation. So we are recording, as Kathy said, and the recordings will be uploaded to the MAFP's YouTube channel for future reference, but CME is only available for those who are live attendees. So the survey link was sent out. Please complete that. And we'll also drop it into the chat towards the end of the presentation tonight. And the information entered there will be used to report your CME. So just as a reminder, this is number 4 of 10 sessions that the MAFP has planned to deliver great interactive convenient CME. And some of the sessions we have coming up are on May 23rd, will be the MAFP 2024 Advocacy and Legislative Review, Supporting Breastfeeding Families in Primary Care on June 20th, Integrating Artificial Intelligence into Family Medicine July 18th, 2023 CDC update on HIV positive birthing persons and the provision of human milk on August 15th, value-based care for family physicians September 19th, and then primary care dermatology in skin of color on October 17th. So if you find these sessions convenient and informative like I do, I just encourage you to spread the word and to your colleagues and have them register for these sessions. So please welcome Dr. Scheer.
Good evening. Let me get my screen share figured out and start a slideshow. There we go. Guess seeing the title slide there then?
Yes.
All right, fantastic. So my name is Jennifer Scheer. I work in a small town of Gerald, Missouri, and I'm a half-time doctor. The other half-time I do administrative work for the Mercy organization. I've worn many different hats in my physician leadership role, several of which have been around coding and documentation. So going to talk you through a few things having to do with that area that is important to all of our practices. Here are our learning objectives for the evening. We want to be able to understand the basics of the CMS hierarchical condition category, hereafter known as HCC risk adjusted model. We're going to talk about the idea that there's a version 24 and a version 28. What are the differences and what's the transition from one to the other look like? Then we'll spend some time describing some of the best practices for accurately and completely capturing all of these. 1 second, I'm going to close my door because I think the cleaners are here. I'll be right back. Meant to do that before we get started. I have no financial disclosures on this topic. Let's launch into our first goal, which is a basic understanding. So what is HCC? Many of you may know this, and so I apologize if it is repetitive. It is basically HCC is a numerical method of communicating how sick patients are. What is the severity and complexity of their illness? It was actually originally designed as an actuarial model. How much do we think it's going to cost to take care of this patient during future years? There actually are several HCC models depending on some of the different payment plans and patient populations. For tonight, we're going to focus in on the Medicare HCC model. It's been in place since 2024 and has undergone several updates and newer versions since that time. How exactly does HCC work? CMS selects ICD-10 codes that, in their opinion and with their help of their actuaries, they feel imply an increased future cost of care for each patient. It groups similar codes and conditions into what are called categories. That's the category. And then each category is assigned a numerical risk score. Higher score meant to be a sicker patient who's going to cost more. And that's also called a coefficient value. So you may see that throughout the presentation. We as providers then submit ICD-10 codes on claims to CMS. The patient is assigned an HCC score, which is based on what the coefficient value is for the different categories into which one or more of those ICD-10 codes falls. And so that is what makes an HCC score. You may hear the term RAF, or risk adjustment factor, thrown about. That is basically the HCC score multiplied by some demographic and other constants that are really not under the control of us as clinicians, and that's going to equal the RAF. And then the RAF is used to set reimbursement rates for all those who care for that particular patient, particularly as we go forward. How does that impact us as family docs? So it's particularly important for those of us who take care of Medicare and Advantage patients, because CMS uses that RAF score to calculate the reimbursement to the Medicare Advantage payer. And then the payers turn around and use RAF along with many other factors that are going to be specific to individual contracts to set the reimbursement rates out to the healthcare providers. It's important to remember that there is a year delay. So the codes that we submit on patients we are seeing this year will actually set payment rates for next year. It's good to know that the HCC score resets to 0 as of January 1st of every year. And so it is important to resubmit all accurate and current codes year over year, and that's on a calendar basis. The average CMS patient, average Medicare patient, is going to have a RAF score of 1.0. So a patient that has quite a few high-risk conditions, maybe up in the 4, 3, 4, even 5 range. Someone who is really quite healthy, maybe 0.5 or even less. That's a lot about money, but it's also important to keep in mind that many of the organizations that look at our care from a quality lens will also use HCC to risk adjust that. And we'll talk a little more about that in a later slide. Here's a little bit more about the impact on the revenue that can come in to provide patient care. Those of you who have been to HCC talks have probably seen pretty similar examples of this. So on the left, this is the same patient, but on the left, the physician has done a very good job of capturing and being very specific about all of the conditions that that patient suffers from. And you can see as we go down the list, not only do they have many high-risk conditions, but there are some that interact and therefore add additional risk. And the fact that the patient has ICD-10 codes that fall into 7 different categories also adds a bit of risk. On the right, same patient, but much more simple, not nearly as accurate coding. And you can see that therefore we miss those interactions and we miss many of the higher risk codes. So the difference in the amount of money that can be put towards that patient's care can be pretty significant. From a quality lens, same patient, but this is the picture that we paint by passing these codes along. If we give the payers or the other quality organizations the impression that the gentleman on the right is who we are seeing, and he's going to go do a little bit of yoga after his visit today, then if he doesn't get his cancer screenings or he has a particularly poor outcome or higher cost, we're going to look like we don't know what we're doing. When we send in the full picture of how ill this patient is, and it's clear that they are much more ill, then those perhaps less positive outcomes are not as much of a ding on us from a quality perspective. So that is really how it's important to us as family doctors. How exactly does it work? It's not quite as complicated as the picture on the right. There are a lot of other little details that we're not going to go into. Hopefully that gives you the high level. And I just had to find a reason to put in this because I think it's a funny slide. All right, so going into the major differences between version 24 and version 28. We have been under version 24 probably for the past 4 or 5 years. And then last year, version 28 was introduced. Why, in CMS's words, did they feel the need to change the model? The model change does help make the transition fully out of ICD-9 and into ICD-10. The numerical values were based on some older cost data, so they felt it was important to update that. They also decided not to include many of the HCCs if they were not felt to accurately predict costs, had small coefficients, weren't very common, or were vague in terms of how we define that from a coding perspective. Many of the differences between version 24 and version 28 are cosmetic. They changed the names and the numbers up. They split a lot of them up and actually added more categories and flipped around how they were mapped. Not really very important to us in our daily practices. They have changed many of the coefficient values. So many of the values of those risk codes have actually gone down. They removed about 2,300 diagnosis codes, but they added back, but only about 270 of those. So in the aggregate, CMS is predicting that RAF scores will probably drop by about 3%, but that's a really very general overgeneralization because it really comes down to each individual patient. But from a global level, those are the differences between the two models. Here at a high view are some of the adds and removes. We're going to go into a little bit more detail on this in later slides, but this might be a high-level glance for you on some of the, particularly the ones that are bolded, or some of the ones that are probably more common in our day-to-day practices. Talk about how the transition is going to occur from one model to the other. So it's been a phased-in process. And you'll see up there that the patients that we saw in 2023, then we are going to set the payment rates for 2024. So the patients that we saw last year and are being paid on now, it was 67% of the older V24 model, 33% of the V28 model. The patients we are seeing now, for which we'll set our reimbursement rates for next year, it's flipped. So it's 33% of the older V28 and 33% of the older V24 and 67% of the newer V28. As we cross over into calendar year 2025, those patients that we see, we will be completely on version 28. But of course, that reimbursement won't be realized until the following year. So this year, we still have 2 feet and a foot in each canoe. Next calendar year, we'll be able to transition fully into the V20. So let's go into some of the best practices to help us as family physicians completely and accurately capture these codes. Of course, it's all about completeness and accuracy. You want to make sure that you document and code all the conditions that are present and relevant to the patient care. It really should not matter whether they carry HCC risk or not. It's also very important to support each one with documentation. It's not enough just to list the conditions that the patient has. They want a clinician, a physician to state what we're doing about it, how it impacts this patient's care. More on that in a minute. It is important to submit each of the conditions that have HCC risk at least once every calendar year. For patients that we're seeing now during calendar year 2024, we want to be cognizant of those that have V24 and V28 risk, make sure that those get on a claim. As we get into 25, we'll be able to really prioritize those that have risk in version 28, obviously, address all those that are clinically relevant, but prioritizing those that remain in the model in the V28. This is a couple of ways to think about supporting documentation. 2 mnemonics that are widely used in the industry, meet and tamper. These are oftentimes used to train our coders. So as they look at our documentation, they will be looking for at least one, more is better, one is enough, of these elements. How are we addressing it? How's it treating? What are we doing to monitor it, et cetera? If they don't see any of these, they are trained not to submit it on the claim. And so then that patient is going to look like the yoga guy and not like the guy with the cane when the claims get to the pay. A quick aside as we're talking about how coders are trained, and that is those two very dangerous words called history of. Obviously, those of us who went through medical school were very used to blah, 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 this is so-and-so with a history of blah, 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 blah. When we think history of, we think that it's something that they've got, that it's ongoing. We got to factor this into their current care. Coders, on the other hand, they see history of, and they immediately go to, it's cured. It's gone. It's in the past. It's no longer relevant. So really cautioning providers to be cautious of using that history of term unless it's truly gone and cured. Maybe words like known or ongoing, current or active would be better to work into your documentation style. In our remaining time, I'd like to take a little deeper dive into these disease states and talk a little bit about the subtleties that we see in our clinical practices and how those translate over into the HCC model, in particular, our V28 model that we are currently and moving even deeper into. Cardiovascular conditions, heart failure is a very important condition from a lot of perspectives, obviously. Most forms of heart failure are included in the HCC risk model, whether it be acute or chronic or acute on chronic, whether it be HFpEF or HFrEF or right-sided, et cetera. Cardiomyopathy, non-ischemic cardiomyopathy also carries risk. It's not necessarily additive, but if you know that a patient is suffering from cardiomyopathy, maybe they haven't actually developed heart failure yet, it's probably worth calling out in your documentation. The easy trap here is to make sure that you continue to document this, even if they're well compensated. And hopefully you've got them on that GDMT and they're doing really well. It's not unlike hypertension. Just because their blood pressure is controlled doesn't mean they are no longer hypertensive. So we want to make sure that we call out that their heart failure is well compensated, but still call it out as a current condition. As we look towards version 28, there's two categories that are what we call constrained. In version 24, acute had a much higher coefficient value than chronic. They've kind of smooshed all those together and actually kind of brought them into the middle. I'm not sure that really matters, but I thought I would call it out as being one of the subtleties to heart failure. Also, what they have done is added a new HCC category for end-stage heart failure. This actually has a very relatively high coefficient value, much higher than the other forms of heart failure, and actually much higher than many other HCC categories. It's up in the range of a cancer type severity. So important for those patients who are suffering from end-stage heart failure to call that out. It is essentially synonymous with what you might call advanced or stage D or NYHA 3 or 4 class heart failure. And down at the bottom is a link to one of the HC or one of the guidelines put out by the AHA. End-stage heart failure has a code in and of itself. It is also important to also designate whether this is HFpEF or HFrEF and chronic or acute, et cetera. So if the patient has end-stage heart failure, you may actually need to submit 2 different codes to fully reflect the severity of their illness. As we turn to coronary disease in the cardiovascular system, interestingly, coronary disease in and of itself does not carry HCC risk. Coronary disease with angina is included. In the V24 model, stable angina was included. So we did a lot of training of providers that if they're on their isosorbide, and even if they're not having chest pain, make sure you still state that they have stable angina. That has been actually removed in V28. Unstable angina remains, but unspecified and refractory and some of the other, and stable have all been removed from V28. Still, of course, important to call out that they have stable angina, but no HCC. Acute MIs are included in V24, still included in V28. Important detail there is to remember that an acute MI can still be submitted for 4 weeks after the event. So whether or not you do hospital medicine, you can still submit an acute MI code for that 4 weeks if you're seeing them perhaps back in the office for hospital follow-up. At the 4-week point, it becomes old MI, which does not have any HCC risk, or history of MI is also acceptable. Vascular disease outside of the coronary bed, always important to think about, of course. From a coding perspective, the complications of the vascular disease is what really matters. And that's even more true in version 28. They have actually removed extremity atherosclerosis without rest pain, gangrene, or ulceration. So intermittent claudication or asymptomatic will no longer carry HCC risk. So important to call out if they have complications thereof. There was a lot of argument about aortic atherosclerosis. It was included in V24. It is, as we all know, incredibly common. You don't have to do too many aortic aneurysm screens to find a lot of that. And whether or not it was clinically relevant was the matter of some debate. It has been removed from version 28, as have those unruptured aneurysms. Obviously, still important to keep that on your radar and follow those ultrasounds, but no longer in the HCC risks. Thromboembolic disease has been included all along and still is. So those acute and chronic DVTs and PEs are important to keep an eye on. Other thrombophilia or hypercoagulable state has been removed. So under the V24 model, the patient was still on anticoagulant therapy, but didn't necessarily still have an active clot. It was often the case where we would call out the fact that they were being anticoagulated for their hypercoagulable state. Still true, but no longer any HCC risk for that particular code. Diabetes, of course, a microcosm of all medicine these days, and so a very busy slide. Key things on diabetes complications, right? Be very specific about any and all complications that the patient has. Remember that hyper or hypoglycemia is actually considered to be a complication. So that elevated hemoglobin A1C or those frequent home blood sugar checks. And of course, then there's the chronic and acute complications we're all familiar with. Uncontrolled diabetes is not really preferred. It is so ICD-9. So not recommended that we use uncontrolled. Instead, diabetes with traditional, probably hyperglycemia, hypo, if that's the case. But those out of control A1Cs really should be referred to as diabetes with hyperglycemia. Don't forget your long-term insulin codes for your type 2s. And then an interesting philosophical discussion for another day. Does diabetes ever resolve? We've had a lot of success with weight loss in many of our patients with diabetes, and their A1Cs normalized, but they're still diabetic, kind of like that hypertensive that happens to have a normal blood pressure. Lots of back and forth. ADA, usually not, according to their position paper, particularly depending on how long they've had diabetes and whether they have complications. But a little light reading for you there if you wish to click on that link. Version 28, differences in our diabetes world. This is another one of those constrained categories. So it used to be that the acute complications had a lot more weight. They've smushed them all together. Shouldn't really matter though. If it's a complication, call it out. You want to make sure that you get that full burden. From an HCC perspective, some of the complications will carry additional weight in and of themselves, not just with the diabetes. And then we saw on our example slide that if we have multiple categories, there is sometimes extra HCC risk added in there. A new category for V28 is pancreas transplant, not super common, but becoming more so. They did remove drug or chemical induced, so patients that are maybe your bad COPD or that's on a lot of prednisone and develops diabetes no longer will have HCC risk, but types 1 and 2, and then the underlying conditions, the pancreatitis, et cetera, still will have HCC weight. All right, pulmonary conditions when it comes to HCC, COPD, emphysema, both included. Not recommended to code that just based on that hyperinflated chest x-ray, but a CT, especially with those emphysematous changes, very reasonable. PFTs are great. I'll call it the symptoms. Not everybody thinks about the fact that a smoker's cough is typically simple chronic bronchitis and therefore included in the HCC model, both in V24 and in V28. Acute and chronic respiratory failure included in both versions. Those of us who focus on outpatient medicine are going to see a lot more chronic, of course. And the definition there is that O2 sat below 91 which many of you may recognize as the same criteria for getting HOMO2 for your patients. So patients that are on HOMO2, give it some thought as to whether they also have chronic respiratory failure. It's likely that they do. One of the key adds for V28 is severe asthma. In V24, the asthma did not have any HCC weight. They have now added severe asthma. Technically severe persistent, but the coders would say that the persistent is kind of implied, so don't get too wrapped up in that. Several definitions of what severe asthma is that I didn't want to get into. A couple of guideline clicks there. Patients who are on maximum dose ICS, maybe the biologics, still having symptoms despite maximal treatment, et cetera. From a behavioral health lens, a fair number of changes in the V28 model, particularly as it comes to our bipolar and major depressive disorders. They have been included, pretty much all of the bipolar and major depressive disorder specificities have been included, and that is changing. So for V28, they have removed the bipolar and the major depression in remission, whether it be full, partial, or unspecified. They've also removed the mild, the active but mild, and unspecified, which means that in Vision 28, essentially bipolar disorder not in remission and major depression, moderate or severe, are going to be the ones that are currently active in the HCC model. Substance use disorders are in the model, including in remission. So hopefully we've been able to get those patients on the right treatment and they're moving on with their lives. But if you're still actively working to help them stay in remission, it's worth calling that out. Those are still in the model unless it's a very unspecified code. And personality disorders are in the HCC model, including version 28. You don't have to be super specific. Even if you can get it kind of to a cluster, et cetera, you can code that and be recognized for the extra work that we all know those patients take to take care of on a regular basis. All right, just a few more. I know this gets a little bit tedious. Obesity and malnutrition, morbid obesity, really no changes there. That BMI over 40, don't forget about those BMIs over 35 with comorbidities, usually 2. Some people will go with 1. I'll leave that to your discretion. In our organization, some of our physicians have gotten a little uncomfortable using the word morbid. It seems maybe a little judgmental. So if you are in that camp, you could certainly use severe obesity or maybe some of your classes to communicate that in your patient-facing documentation. Here, it's important that we as clinicians call out the diagnosis. The coders can look at the BMI, that's easy, but they can't diagnose. It's up to us to call out the fact that this BMI represents morbid obesity either by itself or because of the comorbidities. Important to call out the comorbidities as well. Malnutrition was in version 24. I think that was one of the ones that was very difficult to define and therefore has been removed from version 28 along with some other more rare conditions. Not a lot of changes in the cancer realm when it comes to V28, but no HCC talk is complete without talking about cancer. The important thing here is to differentiate between active cancer and history of cancer. Active cancer is included in the HCC model. Personal history of is not. The definition is straightforward, but just not always easy, especially as patients may flip back and forth. From a coder perspective, they really look at that treatment. The patients on current treatment, they are pretty comfortable coding it as an active cancer. So in the instance that the patient is not being treated and has elected not to treat an active cancer, it's important to document that. And then when we get those notes back, maybe from our oncology colleagues, no evidence of disease, that's the clue that we should flip that over to a personal history of. Don't forget about those secondary or metastatic cancers. They carry a very high coefficient value, as they should. Obviously, terrible conditions for our patients. And it may be obvious to us that this is highly metastatic, this, or that, not always clear to the coders, and may take several diagnoses, that they've got the lung cancer and they've got the mets to the bone and they've got the mets to the liver, etc. B28, not a lot of changes. As I said, they kind of split up and rearranged, and but no significant additions or removals. All right, last one, I promise, because the other thing that you can't talk about HCC without talking about is everybody's favorite status conditions. So still included in the model, solid or hematological transplants. Important to call those out. Ostomies, if there's a hole in the body that God did not make, it probably has HCC weight. So call out those ostomies, call them out every year, talk about how the patient is doing with their ostomy. Amputations are the same and need to be documented every year, at least in your physical exam, if nowhere else. In the version 28 world, they have removed dialysis status, and they have removed some of the subsequent and sequelae of amputations. I don't think that's going to be super important. Lower extremity, absence of lower extremities, still very much included in the model, as that obviously impacts patients' day-to-day life. Those that use a prosthesis, so the presence of the artificial limb, that has been added, and they actually added the phantom pain syndromes as well, given the intensity of treatment that those sometimes require. All right, so that is our content for today. Just a quick review to help everybody remember that HCC model is that numerical method of communicating the patient's severity and complexity of illness, and it impacts our reimbursement as well as the judging of our quality performance. As we move from V24 to V28, there have been about 2,300 removals, not nearly as many additions, and in the aggregate, we expect scores to decrease. We are in the middle of the transition now, and as we move into 2025, we'll be fully in the version 28. Be sure to capture all of the conditions that affect patient care and support them with your documentation. And then I encourage you to spend a little time delving in and learning, as we did this evening, about some of the more common disease states that we see as family doctors. So with that, I will take any questions. Here's a couple of references that AAFP Journal had a great article on the V28 changes. And then for those of you who suffer from chronic insomnia, cms.gov is always available for a little light reading.
Thanks, Dr. Scheer. There was a question in the chat. Do you want me to read it, or do you want to read it?
Yes, I think I can read that. I just have to scroll up. How much do you recommend for us to code chronic conditions? For instance, do you recommend coding toe amputation, obesity, history of cancer, every single encounter? Or do you recommend limiting those to coding only when the encounter was relevant to those conditions? Currently, I'm coding chronic conditions only when they are relevant. That is a really great question. If you would ask a coder that has been trained specifically from an E&M perspective, right? Is this a level 3 or a level 4? They will tell you with great certainty that it has to be relevant to today's condition, today's care, in order to be put on the bill and on the code. If you talk to someone who has more of a risk background or an HCC background, they will tell you that if it's current and active, you can code it. So I think both are probably true. Remember that from a value, severity of illness reflection perspective, as long as you get it in once per calendar year, there's not going to be a whole lot of additive value. So I think coding them when they're relevant is probably the most natural thing for us to do as clinicians, as long as we're sure that we do get all of them at least once per calendar year.
So what about using annual Medicare wellness visits, kind of specifically for capturing the HCCs, particularly since there's more revenue with those in the first part of the year than there is latter part of the year, and you have to reset it every year. I think the issue I have with that is I'm not doing much at those. So does it matter if I'm not saying a lot and I'm just dropping all these HCCs?
No, it actually doesn't. So if you do just a wellness, you're just coding the G, 0438 or whatever, and you want to submit on that claim multiple codes, the meat or the tamper is what matters, as long as you're acknowledging that this is real and it's affecting patient care. Don't forget that if you do an annual wellness, you can actually do an E&M level of service on the same day. There's there's a modifier, but there's no discount. So if you go a little beyond that and you actually are doing some evaluation and management of, say, 2 or more of those chronic stable conditions, then I would not feel bad at all about dropping a level 4 level of service in addition to that annual wellness visit code.
I think the problem with that is having enough time, and you really have to have all of your pre-work done by somebody else, like the HCA and all that stuff.
Indeed.
Or HRA, sorry.
Yeah, the HRA, exactly. A process that is definitely a team-based sport right there, doing that complicated of a visit.
Any other questions?
Hi, my name is Jane Baumgartner. Thank you so much for being here tonight. I do have a question regarding, with documentation and capturing the HCC. We had that discussion earlier in our staff meeting. Is it limited to the PCP or the primary, or can anybody in the care team or even someone who's seeing them for acute visits, can that be documented as well?
It does need to be what's called a qualified professional, which is going to be, in general, a physician or an advanced practice provider. There's a handful of other, like maybe an audiologist. I'm sorry, I don't remember exactly. Nurses cannot submit codes for risk adjustment. Medical assistants cannot. But if and perhaps you work with an APP and they see the acute condition and they notice the patient has diabetes, and that's relevant because they're going to put them on steroids for their COPD exacerbation, absolutely. They can submit that on the claim and it will be accepted for risk purposes.
Thank you.
Any other questions?
Kathy, let me send you the latest slides. I sent them to Bill earlier in the week, but I did change them in the meantime. So I'll send you and Bill the very latest slides for you to distribute.
And I'm sure Bill's going to be sending an email out tomorrow with a reminder to complete the CME reporting and evaluation form. We'll include the link in that email.
That's great. Thank you. So Kathy put that link in the chat for the survey for tonight's CME reporting. So please take a minute to do that. And thank you to everybody who participated, and especially Dr. Scheer for a great overview of this.
Thank you all.
Thanks, everybody.